morning once again from Australia, and welcome to another JBI live webinar. So today we are going to talk about a really interesting topic, and it's about the sustainability of knowledge translation interventions. I think for many of us, we know that there are numerous knowledge translation interventions that are quite effective in improving healthcare practices and outcomes. However, I think the extent to which these interventions can deliver their benefits, over an extended period of time is probably less clear to many of us. So that's why today we have the pleasure of having Professor Sharon Straus, who will talk to us about how to approach sustainability of knowledge translation interventions and research in the context of COVID-19. Before I formally introduce our speaker and formally open the webinar, I just need to go through some housekeeping stuff. At this stage, I would also like to do an acknowledgement of country. So we acknowledge that we are meeting on the traditional country of the Kaurna people of the Adelaide Plains and pay respect to elders past and present. We recognize and respect their cultural heritage, beliefs, and relationship with the land. We acknowledge that they are of continuing importance to the Kaurna people living today. We also extend that respect to other Aboriginal language groups and other First Nations. And finally, if you want to get social, if you want to tweet about this webinar, please use the hashtag JBI Live and also tag us at JBI-EBHC and myself at Lucy Lizarondo 20. So now I have done the formal housekeeping and I'm ready to introduce our very esteemed speaker. So today I have the honor to introduce all of you Professor Sharon Straus. Professor Straus is a geriatrician and clinical epidemiologist who trained at the University of Toronto and the University of Oxford. She is the director of the Knowledge Translation Program and physician-in-chief, St. Michael's Hospital, and professor in the Department of Medicine, University of Toronto. She holds a Tier 1 Canada Research Chair in Knowledge Translation and Quality of Care and has authored more than 400 peer-reviewed publications and 3 textbooks in evidence-based medicine, knowledge translation, and mentorship. Since 2015, she has consistently been the top 1% of highly cited clinical researchers as per Web of Science and has an H index of 86. She holds more than $57 million in peer-reviewed research grants as a principal investigator. Sharon has also received national awards for mentorship, research, and education. So I will now hand over to Sharon.
Great, thank you very, very much. And just while we're getting those slides set up, just welcome everybody. And it's great to see we have representation from around the world. So this is really fantastic. I was saying to Lucy and Danielle when we started that I was very jealous because at the very beginning when we first were chatting, Lucy and Danielle were in the same room together and they were not wearing masks. So I was saying that coming from Toronto, where we're used to sharing when we share space that we're all wearing masks and usually face shields as well in the hospital, it was really, really lovely to see that there's hope in the future for us. Excellent. So hopefully everybody can see and hear me, and in particular, so thanks so much everybody for joining us. Thanks so much Danielle and Lucy for organizing this and providing me with the opportunity to chat with people. And before I started, I wanted to acknowledge the land on which I feel very fortunate to work. So I'm based at St. Michael's Hospital in Toronto, and it's the traditional territory of many groups, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, the Wendat, and it's now home to many diverse First Nations, Inuit, and Métis people. I also wanted to acknowledge that Toronto, where we work, is covered by Treaty 13 with the Mississaugas of the Credit. Today in Canada, we are grieving 215 Indigenous children who lost their lives at a residential school in Kamloops, BC. And we are continuing to understand the devastating impact of the residential schools in Canada and the massive impact that this has had on our Indigenous communities. Our thoughts are with the families, with their nations, and with all the survivors of residential schools in Canada. I also acknowledge that we are committed to recognize, honor, and take action on the Truth and Reconciliation Commission and on the missing and murdered Indigenous women and girls inquiry calls to action. So with regards to competing interests, so some of the material that I'm going to be talking about today is from a book that I wrote on knowledge translation along with Ian Graham and Jacqueline Titro. And just to keep in mind that I don't benefit from the royalties from that book. It actually goes to a fund for trainees, and I don't have any control over that fund either. So just so that you're aware of that. So hopefully by the end of the session today, we'll have spoken about these things, and in particular, thinking about what sustainability is and why it's particularly important to implementation. Thinking about what are the different frameworks and tools that we can use when we're planning sustainability. And then also thinking about how do we evaluate sustainability. And then finally, I wanted to touch briefly on the implementation challenges that have been occurring during the COVID pandemic, also thinking about it from a sustainability perspective as well. So this is kind of where I got started in really thinking about implementation and using evidence in practice. And after I did my clinical training in Toronto, then I went away to the UK to do my research training. And one of the first projects that I worked on with my supervisor, Dave Sackett, was how do we bring evidence to the point of decision making? So at that time when I was doing my fellowship, it doesn't seem that long ago, but clearly it was a long enough time ago that we didn't have computers on the wards. And so we had to build a system where we would bring the computer to the wards with us. And so you can see here that we had a laptop computer, and on the laptop computer, we had various high quality evidence resources. So things like we had a subset of Cochrane, we had a subset of PubMed. We also had a resource called our critically appraised topics, or our CAT bank, that were basically one pagers of critically appraised topics. And then we had behind the laptop, you can see we had a projector, and then we had this portable screen that we would take around with us. And anytime we went to the bedside and a patient had a question, we would do a search, and we would search for the evidence. And it was very much focused on how do you bring evidence to that point of decision making with the patient and to the individual patient clinician interaction. But then as I was kind of doing my training, started to think about, well, that's great at the individual clinician patient interaction, but what do we do beyond that? And I came across this paper that Richard Grohl had written a few years previously, where he talked about how evidence-based medicine should be complemented by evidence-based implementation. And this really kind of caught my interest, because it was thinking about how do we use evidence, if we're thinking about it at a clinic setting or at a hospital or at a state or province or territory. How do we think about using evidence and really focusing broadly on the strategies for doing evidence implementation? And we all know that changing behavior is challenging. So any of us who have tried to do any of these things knows how challenging it is to not just initially start the implementation, but then also to really embed it within our routine day-to-day activities and sustain this behavior change over time. And certainly during COVID, we've all kind of struggled with some of the behaviors that we've had to do. So I wanted to hear from all of you, and so Lucy and Danielle, if we can put up the first poll to ask people, have you tried to sustain any of your implementation activities? So yes or no? And can we see that? So we've got about 70% of people have said yes, 30% have said no. Great, excellent. So now I want you to put in the chat feature, what were some of the challenges? So for the 70% of you who try to focus on sustaining implementation, if you can put in the chat feature what some of your challenges were. And then also if you could also, the people who haven't tried sustaining implementation, if you could share with us some of the things that you have found that you thought about that maybe would be challenges to sustaining.
Okay, so some of them have said it's about maintaining fidelity and also the turnover of leaders, employees, and team members. And one of them said that it's not often being considered, and looking at so many frameworks not being addressed, or they don't necessarily cover sustainability. Someone has said that there's a need to reinforce the benefits of behavior change. And it's one participant said that making it a habit is quite challenging. What else have we got here? Adapting evidence to specific needs. And also here we've got one of the participants said one of the challenges he experienced is intrinsically motivating healthcare providers. What else have we got here? It's very time consuming to continue auditing feedback. Also finding champions is a challenge because they need to move on. We've got another one saying maintaining engagement, involvement, and resources can be quite challenging. What else? People are keen when receiving support, but without prompting, the behavior is not sustained. So it costs a lot of money to provide support and prompting. Changing priorities is one of the challenges identified as well. Okay, so we've got
Yep,
interesting.
that's great.
Okay, so I think that's probably more
Perfect.
than enough.
Yeah, no, that's excellent. Thanks so much, Lucy, for reading that. That's perfect. Thank you. So lots and lots of challenges that you've identified, and so you probably are thinking, it's kind of depressing. There's so many challenges to sustainability. It's no wonder that that we're not able to sustain things in some cases. And you've all highlighted, some really critical things, and we're going to talk about some of these things, like what do you do when the leaders within your organization have changed, for example, and then also balancing adaptation and fidelity. So thinking about that careful balance that we need to consider. Some of you also mentioned then potential frameworks, and we'll touch on those as well, because there's lots of different theories, models, and frameworks that we could be thinking about, but which are the ones that really include sustainability and include it in a way that it's accessible for us. And then some of the other things that you mentioned as well, like, the changing priorities. So absolutely, like, we often see this, that we're initially kind of focused on an implementation strategy in some particular area. And then all of a sudden that, something else happens and takes priority, like COVID, for example. And so then all of a sudden then sustainability of other strategies is threatened. And then you've also mentioned the time and the other resource requirements. And again, we can't underestimate that. And we'll speak to that as well over the next little while. So, we kind of briefly alluded to how challenging, not just the initial behavior changes, but being able to sustain things over time. And looking at a recent systematic review of healthcare professionals' adherence to clinical practice guidelines, it's interesting, there weren't a huge number of studies that were identified that really focused on sustainability, but what was found in this review was that adherence did decrease after more than a year in about 50% of the cases, and even then, if you look at this, that there weren't a large number of studies that followed things over a long period of time, and we'll talk about this as we think through the definition of sustainability as well. Now, for those of you in Canada, probably have seen this quote before, that Monique Began, who was a health minister under a previous Prime Minister Trudeau, so under Pierre Elliott Trudeau, she wrote a CMAJ commentary a few years ago where she called Canada a nation of pilot projects that were we're very good at kind of doing initial implementation. We're not so good at kind of doing the follow through and doing the sustainability. And, I don't think that in Canada we're hugely unique in that, compared to other places. But, it does lead to a lot of waste in the sense that we initially spend money on the implementation, less so than on the sustainability. And so it does lead to research waste. And for those of you who have seen the series in the Lancet on research waste, and there's been several articles in this series, you've seen kind of the evidence pipeline and the sources of waste along the way from when research is done to when it's getting implemented. And the lack of our ability to sustain evidence in practice or policymaking does contribute to this global research waste that we see. And so we know that sustainability is important for a number of reasons. And Enola Proctor did a really nice paper a few years ago in Implementation Science, where she really called it kind of one of the big frontiers in implementation science, because we hadn't really spent a lot of time thinking about sustainability. And some of the things that I think are important to consider is that even if something has a very small beneficial impact, the impact over time is substantial. And so we don't have to think about, yes, maybe it's just a small benefit over this next year. But if we think about it over the next 3 years, 5 years, 7 years, that potential impact is quite substantial. We also have to think about that, if we fail to sustain something, so for example, if we initially engage a whole bunch of decision maker partners and stakeholders in implementing something, and then all of a sudden, like a year from now, we just kind of wash our hands and are out the door, the failure to sustain that and to set up a process for sustaining that decreases the chance that we're going to be able to engage those people in future. They're going to have less confidence in the ability to sustain something or to initiate future implementation efforts. So we also have to think about those risks when we fail to consider sustainability. And Enola really talked about then sustainability as being really one of the most important threats to implementation, and that we really need to avoid this model of doing the implementation work, pilot study, and then not thinking about sustainability until it's too late. And one of the other things that Enola identified was that we didn't really have a consistent definition of sustainability, and in particular, what is it that we're sustaining? And so we did a concept mapping exercise, and looking at the literature and looking at the different definitions based on a review that we did. And this is how we defined it, that after a defined period of time, both the clinical or the policy, depending on the sector in which you're working, and the implementation interventions continue to be delivered. Because we've got the clinical practice and then the implementation practice or intervention that we're using to ensure that evidence is being used. And so then, are those being sustained? Then are the behavior changes being maintained? And again, within the healthcare system, there could be several levels of behavior change that we're considering, from the patient through to the clinicians, to the policymakers, to the organizations. So it's thinking again about, who's sustaining the behavior change. And then thinking about that, we talked at the beginning, some of the people talked about the challenges of fidelity versus adaptation. And absolutely, we have to think about both the clinical and the implementation and interventions may adapt, but we're still monitoring outcomes over time to see, are we still seeing the outcomes that we were anticipating and that we were targeting. And so we really, when we're thinking about sustainability work, I think it's important that we upfront define what is it that we're trying to sustain. Are we sustaining our implementation strategy? Are we sustaining the clinical intervention? Are we sustaining the impact? What is it that we're trying to sustain, or is it all of these things? And that's why I think it's really important that when we're developing any of our implementation strategies, that we think about sustainability up front, and then think about what it is that we are sustaining. So are we sustaining the guidelines, the clinical piece, or the policy, or are we sustaining the how? So I think it's really critical to upfront consider that aspect. Similar to kind of thinking about all the different terms that people have for knowledge translation, lots of different terms for sustainability as well. And sometimes people talk about, maintenance or continuation. They basically all mean the same thing. But just as a word of warning, if you're looking for literature in the field about sustainability, you might have to use these other terms to find the articles that are relevant. Similarly, as I mentioned at the very beginning, there's so many different theories, models, and frameworks that we could consider using. And I think, again, this is one of the challenges in the dissemination implementation field or knowledge translation field, that so many of these exist. And how do we choose? How do we select the theory, model, or framework that we want to use for our particular project? And so Lisa Strickler, who's one of my PhD students, led us on a review a few years ago that was done actually for the Canadian Partnership Against Cancer. And it was really done to identify all the different theories, models, and frameworks for chronic disease management or cancer prevention and control. And basically there were quite a few implementation theories, models, and frameworks that were identified, but Lisa also identified that the bulk of them were used only once. So kind of in one paper, they were maybe described. But then she also looked at how many of the theories, models, and frameworks describe the implementation process, right from kind of the beginning through to understanding what the gap is, to the barriers and facilitator assessment, to developing your implementation strategy, all the way through to sustainability. And we called these the full spectrum theories, models, and frameworks. So they would include sustainability. And so there were 26 of those. And of those, then there were 10 that address behavior change at these different levels. And so when we're thinking about sustainability, then these are the theories, models, and frameworks, and that we could potentially target for our sustainability work. And I don't expect people to see the detail on this, but if you go to the JCE paper, it breaks it down. And so you can see that the ones that include, in particular, sustainability as a feature. But there are also frameworks if you want to purely focus on sustainability alone and you don't want to think about the whole implementation process. And David Chambers had this nice paper on the dynamic sustainability framework. And the thing that I like about this is that it really highlights how we need to consider sustainability and how, kind of balances what we talked about before, kind of the adaptation and the fidelity, but also really thinking about how things change over time within the healthcare context. And how sustainability then, really needs to be, and our approach to sustainability really needs to be nimble and flexible, and so dynamic in that sense. So we've talked briefly about kind of different theories, models, and frameworks, and then it's, is sustainability being measured, and how could we potentially measure it? And part of this goes back to what it is that we're going to be sustaining. But again, in a systematic review that Andrea Trico, who's an amazing scientist in our knowledge translation program, led us on a few years ago, did a scoping review on implementation interventions for management of chronic disease in older people. And one of the things that we were interested in is we wanted to look at kind of how many of them considered sustainability, definitions of sustainability, those kinds of things. Overall, we didn't find a huge number of studies, that went beyond kind of 1 to 2 years. So that's kind of one of the things that was interesting. Most of the studies targeted patients, so started thinking about sustainability from, is this patient continuing to use the particular piece of evidence or behavior? And in particular, very few of them reported adaptation, which, as we talked about, we do expect interventions to adapt over time. And whether that's the clinical or the implementation intervention, we expect that adaptation to happen over time. And none of the studies actually reported using a framework to consider sustainability. And again, I think it highlights kind of a gap in our field. So there's also been a systematic review of public health interventions, and again, not being substantively different from the previous review that I highlighted, that in terms of kind of what they're targeting and whether or not they're using theories, models, or frameworks to inform their work. And then we did a study as well looking at whether or not in grants that are funded by the NIH in the US, how many are focusing on sustainability, and in particular, do they mention sustainability at all, or do they use any frameworks that would consider sustainability? And part of this relates to, I think our grant funding mechanisms don't really set us up well to be able to study sustainability, because we usually get funding for a certain period of time, and and we want to follow things 5 years down the line. It's typically much more challenging to do. But the other thing that we found is that there was really a lot of disagreement on what sustainability involved, and again, it goes back to those different concepts of what it is that we're sustaining, and is it the clinical intervention, is it the implementation strategy, is it the ultimate clinical outcome that we're sustaining? And so there was a lot of or there was a lack of clarity really around what it is that people were wanting to sustain. And so then looking at, again, on some reviews that have looked at how sustainability is being measured, most commonly people looked at, if they were implementing a program, did that program stay in place? So if I was doing like a vaccine program, was the vaccine program, implemented over time? And so part of it then is thinking about, well, maybe I implemented that vaccine program, but was I still hitting my target in terms of the number of people getting vaccinated? So, what is the outcome that I should be looking at? The other thing that we found is that a lot of studies only measured sustainability maybe kind of, right after the implementation, and then maybe like a few months, like 6 to 12 months later. And again, when we're thinking about sustainability, ideally we would want to look at a timeline beyond that. There's been lots of, again, studies looking at different approaches to sustainability, and again, thinking about what it is that we're trying to measure. And I think one of the aspects of this review that I wanted to really focus on was they also spoke a lot about the sustainability of the engagement of the stakeholders, because as we all know, when we're doing implementation work, it's we spend a lot of time on the initial developing the relationships with different stakeholders and things, and how do we keep those relationships flourishing throughout the implementation process, and sustain those relationships, and how does those change? And somebody mentioned, when I asked about challenges to implementation, somebody mentioned the turnover of leaders, and similarly, you can get the turnover of various different partners involved with an implementation project, and that really does sometimes threaten the sustainability. And one of the projects that I did a few years ago, we were doing an implementation strategy in Northern Ontario focused on falls prevention and osteoporosis management. And this was a study we did with colleagues up in Northern Ontario, along with Lisa Dolovich from McMaster. And we had engaged the people from the Ministry of Health in our province, because they had an osteoporosis program that they were implementing, and we thought there was good alignment. Within the 3 years that we were doing this project, we went through 10 different people within the Ministry of Health, because they were changing over a fair bit. And that does, it can be seen as a challenge, because you're constantly developing, new relationships with people. And so it's, how do you respond to that, and how do you do things like, so for example, we created these one-pagers then that would quickly bring people up to speed, because we knew we were probably going to get somebody new within the ministry. And so we had these one-pagers, and then we would also buddy up with people so that we could kind of meet with them very quickly, and because we knew they were so busy and we didn't want to take up a huge amount of their time, but we wanted to make sure that they knew what was going on. And so developing strategies like that. And then also thinking about that when there is turnover like that, and when people leave organizations and go somewhere else, those people are infectious vectors. And if they were really excited about implementation and about sustainability, they will become infectious vectors and do other implementation work. So I think that's a really a positive thing that, that we see happen over time as well. So this is kind of the approach that we use when we're thinking about sustainability, kind of putting all those different pieces together, all the different reviews and things that I've talked about, and really kind of breaking it down into, you know, the program, the clinical intervention and the implementation strategies. And in particular, when we're thinking about that, it's thinking about from the very onset is having these as factors that we're considering when we're developing our implementation strategy, and thinking about, you know, how are we going to monitor it over time so that we can adapt it. How are we going to make sure that it's accessible to the different populations, and really focusing on those aspects that are relevant to that clinical intervention that we initially start with. Then also thinking about the implementation team itself, and we've touched briefly on the roles of those different stakeholders and needing to engage them. But it's also thinking about how those people might change over time, and you know, and they might facilitate access to other networks of individuals that we should bring in, and similarly thinking about what's the capacity in our team, what's the skill sets, what's the mix of individuals that we potentially need. And how do we keep people engaged throughout this entire process so that we can sustain implementation over time? It's also thinking about the implementation setting itself. And again, if we're implementing something across multiple different settings, it's really having a deep understanding of the settings in each of those contexts, so that we can make sure that we're monitoring that over time, and that our strategies, our implementation strategies in particular, are going to be modified based on the changes. And so if there is a change in leadership or a change in priorities, that we are going to be aware of that, and then we can implement the adaptation as needed. And then also thinking about then the system factors. And from this perspective, it's really thinking about things such as the funding that's available. What's going on from a systems perspective? What are the other priorities within the healthcare system that we need to think about? And what are the other you know, strategies that might be coming down the line? What are the other priorities? What are the, you know, if there's a new government, for example, they're going to have different priorities. So how do we monitor for things like that? So it's really thinking about, from a systems perspective, what are the factors that might influence sustainability? And so when we're developing our implementation strategies, we have a checklist that we go through all of these things, and we have our team come together and really think about all of these things as a group, so that we can then, from the beginning, start thinking about how we're going to develop our implementation strategies so that they're going to be sustainable, so that we don't invest in a really elaborate multi-component implementation strategy that we're not going to have resources to continue, you know, 2 years down the line, 3 years down the line. And so these are kind of our sustainability planning steps that we use. And again, like we do this right from the very beginning when we're thinking about sustainability. So, you know, as I said at the beginning, defining sustainability. So what is it that we are trying to sustain, and where is it being sustained? So in what contexts, and really having a deep understanding of that. Secondly, thinking about our stakeholders. And again, these are people that could change over time. So who's engaged today is not going to be the same people who are engaged 1 year, 3 years down the line. But it's having an understanding of who the target groups are. So is it policymakers? Is it, you know, if it's in a hospital environment, like who are the managers within the hospital environment who need to be engaged? It's thinking about all those different factors, and all those different aspects of the stakeholders, you know, patient groups and members of the public, clinicians, making sure that we identify and then figure out how we're going to engage them and keep them engaged throughout. Then the third thing is around assessing the context for sustainability. And so having that deep understanding of the settings in which we're doing things, and knowing that, you know, what we do in one setting is not necessarily going to be, you know, easily plugged into another setting. So making sure that we have spent enough time and enough thought to understand how we're going to monitor that over time and think about what are the other potential changes that we then have to make. And then it's doing our sustainability strategy and evaluating it. So constantly monitoring it to help us to understand, is it still achieving what we think it should be doing, and if not, why not? And just as an example that we've all been faced with in the last little while, it's thinking about with public health measures. So, how difficult it's been to do things like, sustaining wearing a mask and hand hygiene and physical distancing. And I can tell you, working in a hospital, like it's been such a long 18 months where, people have to wear masks and face shields all the time, and, and not being able to interact in the same way. And when the holiday seasons come around and people want to be able to share meals together in the, in break rooms and things, and, or, on the wards and stuff, and not being able to do that. And, not being able to have the potluck on the medicine ward, like those kinds of things. I think being able to kind of sustain those changes is, can be quite challenging. And so it's thinking about then, again, who are the stakeholders, what's the context in which we're doing this, making sure that, our messages are clear and are actionable. In this particular case with these public health measures, it's, supporting the social norms, for example. So, we're gonna protect each other, and this is us doing it for each other, and this is part of our identity. We look after each other, we care about each other. So really supporting the social norms. Supporting the group membership aspect as well can be helpful in this particular case. So, everybody doing it together, and being inclusive about it. In this particular case, again, avoid messages based on fear. So, we often talk about the carrot versus the stick, and, we'd much rather use a carrot than a stick around this. Making sure that we're explicitly linking our guidance and our messages to the evidence so that people know. And I know this has been challenging during COVID because the evidence base is changing so rapidly. And so, what we're saying today sometimes differs from what we said yesterday, because of the evidence changing. And so, but I think as long as we're transparent and explicit about that, it's helpful. And then thinking about who are the messengers. So who are the people who are going to be talking about wearing the mask, and, showing kind of local champions and people that, people that you recognize who are wearing masks, and saying, this is why I'm wearing a mask. And then monitoring this over time. So, so that we're seeing, are we still, doing the appropriate PPE maneuvers. And really overall, it's engaging, the targets for the activities in the work, so that we really focus on co-creation of the implementation strategies, so that, whatever we create is going to be more likely to be used if the end users are involved from the beginning. So I wanted just to touch on as well some additional strategies that I think, again, have not necessarily been considered well in implementation science, and when we're thinking about sustainability. And in particular, thinking about, as individuals, we all have different characteristics, we have different lived experiences, we have different contexts in which we were, born and raised. And so these all make our approaches to things very different. We have different biases. We view things in a different way. We have different experiences within the structures of power and oppression. I mean, me as a white woman, I've had, advantages in my career as being a white woman in some cases, and disadvantages in others, depending on the context. But it's thinking about when we're doing any kind of implementation work, it's thinking about all of these different aspects, and the individual characteristics, but within that system of power and oppression and privilege, that lead to things like discrimination and racism. And when we're doing any kind of implementation work, it's thinking about these factors and using this intersectionality lens when we're developing our implementation strategies. And this starts right from thinking about, us as team members to the other people that are on our team, how we identify other team members to join the team. are we reflective of the population that we're trying to target? What are all the different biases that we're all bringing, those different lived experiences that we're all bringing to this implementation work? So it starts right from the team building all the way through to our processes for stakeholder engagement, the way we communicate with people, the way we, our approaches to dealing or to achieving consensus need to change and need to be tailored to these different experiences. Thinking about, the implementation strategies and how they should differ. And so, there's examples, for example, where school-based interventions to prevent domestic abuse for children reported that LGBTQ2S youth felt excluded from certain programs. And so then thinking about how do we develop implementation strategies that are co-created with them, that meets their needs. There's lots and lots of examples of this in the implementation world where we're not thinking about these factors. And then as a result, we actually worsen health disparities. And so similarly, sustainability has to be considered using an intersectionality lens, again, right from the stakeholder engagement all the way through to thinking about how we're going to continue with our implementation strategies. If anybody's interested, we've got a number of different resources that we've co-created with colleagues on using an intersectionality lens and these systems of and structures of not just the identity factors, but the structures of power and oppression to develop implementation strategies, and really reflecting on the important work that Black feminist scholars like Kimberly Crenshaw, who really came up with this concept and has really led the way. And then we've created, if anybody's interested, we've modified some of the implementation theories, models, and frameworks and created a toolkit for people to use and to start thinking about this when you're developing your implementation strategies. And then also thinking about how do we know when we should stop doing something. So I always worry too that sometimes we can get so invested in something that we forget about, sometimes it's okay to stop something and do something, implement something else as evidence changes. And so it's also important to think about de-adoption and sustaining de-adoption. And so Dan Niven, who's one of my PhD students, who's a critical care physician out in Calgary, did some really nice work where he again looked at, the gaps in the de-adoption area and how, and this was a scoping review that was done. There's very little work that looks at sustainability of de-adoption, and stopping something, is really hard to do as well. Now, if we can have the next poll, I just wanted to ask people who had to pause your research during COVID pandemic, or did you? Yes or no? So we've got about a 50-50 split. Interesting. Okay, so that's excellent. So so I wanted to touch a little bit on what's been the impact of COVID in particular. And I'm going to skip that one, and we'll just keep going. But briefly, just in the last couple of minutes, really talking about how, with all the challenges with COVID, and there's been it's been a distressing time for everybody. It's been really stressful and tiring and exhausting for everybody around the world. I think one of the interesting things is that for those of us who like implementation work and like doing implementation science, there's this, one of the silver linings, and has been like the entire thing is about implementation and how do we do implementation in a very nimble, flexible way. And it could be anything from preventive interventions to reduce transmission, to sustaining interventions such as we talked about with PPE and physical distancing, or implementing the various test and trace models, or implementing wastewater surveillance, or managing outbreaks. Like, there are so many different implementation strategies and implementation problems that have been identified during the pandemic, and right from prevention to testing all the way through to treatment. But again, one of the biggest things has been, it's highlighted these massive health disparities that we have. And I think again, it's is really shed light on the importance of us really investing in understanding and optimizing these health for individuals who have these marked and well described vulnerabilities. And so I've seen that as something that, has really posed a challenge to those of us in implementation to tackle and to do this in a very serious and thoughtful way. There's also been some unique challenges to implementation work during the pandemic. And one of the things that we've all been faced with is just how rapidly the evidence is changing, and how challenging it is from 1 minute to the next, where guidance within a province or a state or a territory can change. We also know that it's been challenging, if you're trying to do engagement with knowledge user, in particular with patient-oriented research, the limitations that we've got with, not being able to meet with people in person, and, and with a lot of other activities, with the rapid response for a lot of research that we need to do, it has impacted our ability to engage partners in some of the research in a way that we would do in non-COVID times. I think it's been something that's been quite challenging. And then similarly, we know that people, with just the human resource element, that people have been redeployed into different settings, their research has been paused. The impact that people have had with the school shutdowns, with women who are looking after their children at home while they're still trying to work, while they're also looking after older parents. In many cases, and they're also clinicians and trying to do that, and then also doing research. Like, the impact on the individual has been massive. And anybody who's doing implementation work, and also the distress. I think there's so much distress for people, seeing and being involved with providing care for patients with COVID. No matter what settings we work in clinically. There's a lot of moral distress related to what's been going on. And then we've also seen kind of different research methods. So, being able to rapidly get REB approval, rapid data collection, so that we can do qual and quant, really, really quickly, so that we can do robust research that's responsive to the needs of our patients, and making sure that we have the relevant data, and being able to compare and contrast across countries. So I know that was kind of, I just vomited a whole lot of stuff at you, and really wanted to just finish by summarizing that I think sustainability needs to start right at the beginning of implementation, and that we can select, one of those 10 frameworks, 10 out of the 26 full spectrum frameworks. Pick one of those that considers sustainability, and then think about what it is that we really are trying to sustain and how we're going to measure it over time. And then finally, use an intersectionality lens when we're doing that. Really think about the intersection of the social characteristics with the systems and of bias and power and oppression, to really think about, is what we're doing going to increase a health disparity, or is it going to narrow a health disparity? Because to me, this is our moral imperative right now, is to address the health disparities that we have and that we've seen. So having said that, thank you very, very much, everybody. There's my contact details if anybody wants to contact me afterwards, and I'm open to questions. So thank you.
Yes, we've received a lot of questions. I think you can see some of them already. But let me just go through some of them. We've received some comments in the chat as well. So we'll try to go over all of those questions as much as we can. The first one, we've got here, how do we help, the concept of sustainability? It sounds very complex, but how do we help busy and stressed clinicians to get excited about implementation as well as sustainability? Do you have strategies that you can share with us to engage with point of care clinicians?
Yeah, so that's a great question, and thanks so much. And so absolutely, it's about showing, it's about kind of giving people the examples, the stories, and seeing what are the problems that they're facing, and involving them from the beginning. So what are the issues that they're facing that we can work with them on solving. And so whether this is so finding out kind of more the context in which they work, and see what are their biggest challenges. And I always say, like, I always tell everybody that I have the best job in the world because I get to see patients, and the patients and the trainees that I interact with leads to the questions that I want to answer. And we co-create the research together. And I think that's, I always think that, it's always good and effective if we can engage clinicians in that way to see what's the context in which they're working, what are the problems, the challenges that they're facing that they want help with to answer. And then partnering with them on how to do that. And then also partnering with them on saying that, we're not just going to walk away. Like, once we've kind of, engage them on something and then it's like, great, job done. It's really keeping them engaged and making sure that, we really embedded the implementation and the clinical practice, embedded into the system, so that they don't feel like that, we've abandoned them in any way.
So you've highlighted there the importance of having working closely with clinicians, which is probably one of the most important stakeholders when we plan for interventions for sustainability. Would you say then that, because you've talked about earlier, you've talked about having to consider stakeholders, the context, the different sustainability strategies, and these are also some of the factors that you would consider, and that would affect the initial adaptation of the KT interventions. So, would you say that the factors that you consider during the initial adaptation of the KT interventions are also the same factors that you would consider when you think about sustainability, or would they be quite different, or some of them would be more dominant at certain phases?
Yeah, so again, a great question. And I think it's gonna, I think the answer is always it depends, right? So, um, because sometimes the initial issues that you're going to consider, like the barriers and facilitators to the initial implementation,
Mhm.
are going to be the same as what it is, down the line. But we also know that that's not necessarily always the case, and it can change. And it can change for a number of reasons. One is that, because the context in which, we're delivering care, for example, can change. And so then, it could be quite different. And I was just thinking, one of our sustainability projects that we did a few years ago was we were doing a delirium prevention study on older patients who had hip fractures. And we were monitoring it over time, and we found, like, basically our delirium rates got cut in half. And then about a year or so into it, we saw the delirium rates starting to go up at one of our sites. And when we started looking at it, we said, we didn't, there wasn't anything obvious. And then we started interviewing people to find out kind of what was going on those units. And it turned out that, the champions who were really kind of, the local opinion leaders were identified by hospital management as being, great implementation people, and they got pulled out of that unit to do a project somewhere else.
Okay.
And so then, it was us then being able to identify that, well, to be able to sustain this, we needed to identify, who's going to be this next champion. So it's being able to kind of, monitoring on an ongoing basis and identify potential things that might come up. Similarly, we also know, even from a human resources perspective, people change over time. The money that you have, in place now
Mm.
might not be the same as 3 years down the line. And so then, are you going to be able to deliver your strategy in the same way? And so then it's thinking about your sustainability strategy is going to have to consider all of those aspects.
Yeah. So it's a very dynamic process, and it's quite complex.
Mm.
Now, the toolkit that you've shown us earlier around intersectionality lens. So those resources that you've mentioned earlier, the toolkit, uh, would that just be around intersectionality lens, or would that help us go through the process for thinking about sustainability strategies?
Yeah, so the resources that I showed talk about the approach to using an intersectionality lens in knowledge translation and use it for certain steps within the knowledge translation process. And then some of the other resources that we have on our website also talk about sustainability. So a lot of the tools that I mentioned around, the definition of sustainability and things like that, those are also on our website.
Okay, thank you very much. We still have a few more to go through, but I'll probably just ask the last question now because I'm really mindful of the time. Um, there is a question about, do we need the same robustness of evidence to de-implement as we do to implement?
Yeah, so again, a great question, and so absolutely, we have to think about if we're going to stop doing something, there's got to be evidence saying that this is potentially harmful, or there's something else that we should be doing instead, and I think that that's one of the things that choosing wisely is really focusing on is what are the things that we should stop doing. And so it is looking at what's the evidence in support of that. And so, for example, one of the things that Dan Niven looked at, which was one of my PhD students that I mentioned, he looked at tight control of blood glucose in people in the ICU, because there was initially a very small randomized trial that showed that if you achieve very tight blood glucose in people in the ICU, that you might have better outcomes. And so then everybody kind of shifted, based on that one study. But then larger studies came out, and then a systematic review coming out showing that there's actually potentially harm from that. And so then it was based on that they focused on the de-implementation. So it is being able to look at the body of evidence to support that for sure.
Okay. Thank you very much once again, Sharon. We've really enjoyed that presentation. I wish we can go through all of the questions we've received, but we're running out of time. So thank you very much again for that. And before I formally close the webinar, I just want to let everyone know that at JBI, we offer a range of education and training programs, which are focused on evidence synthesis and evidence implementation. And if you want to know, to get more information about this, please visit the jbi.global website. And if you want to stay with us, stay in touch with us at JBI and find out when our next JBI live webinar will be, please subscribe to JBI Buzz through our jbi.global website. So our webinar for today and the previous ones we've had, if you want to access them in the future, they will all be accessible via the JBI YouTube channel. And then finally, because we are committed to making sure that whatever we organize for next time in terms of webinar are relevant to our audience, there will be an evaluation. So an evaluation survey will pop up after this webinar is closed. Please take time out to fill that survey because we value everyone's feedback. So once again, thank you very much for joining us, and we'll see you again in the next JBI webinar. Thank you.